We prepared one case for this Hong Kong therapeutic endoscopy live course. Although it is Zoom meeting, I think it's our great pleasure to join this wonderful event. We prepared one case, so we will start the case presentation first.
We'll start the case presentation. A 74-year-old female patient came to our clinic for evaluation of pancreatic cyst. She had known to have the pancreatic cyst from a routine checkup 8 months ago. The follow-up contrast-enhanced computed tomography a week ago showed an 1 centimeter increase. Today, endoscopic ultrasound exam is planned for morphologic evaluation, cystic fluid aspiration, and Moray microforceps biopsy for histologic diagnosis.
Yes, we prepared one case of pancreatic cyst. So I will do EUS examination of the cyst. Firstly, we will check the morphology of the cyst and how morphologically we are trying to differentiate pancreatic cystic lesion. And secondly, I will try to aspirate the cystic fluid for biochemical study, CA, amylase, or sometimes cytology, those kind of things. And also nowadays we are trying to analyze glucose also. And finally, we are going to use Moray forceps biopsy to get the histologic diagnosis. This is Moray forceps from US endoscopy. Can you see this?
Yes, we can.
Yeah. If the jaw is opened, it goes through the 19-gauge needle. When the forceps is opened, it is about 4.3 cm, 4.3 millimeter in size, and the shaft is about 0.8 millimeter, very thin shaft, but relatively large jaws. So if we use wisely this forceps through 19-gauge needle, you can get the fairly large amount of tissue, and we can get histologic diagnosis. I already inserted my echo endoscope into this patient. And as usual, I do EUS examination in a sitting position. Can you see my face?
Yes,
sitting
very well.
On my chair? Yes, yes. This is my routine examination position. And now I inserted my echo endoscope into the stoma, lower body. And from here, can you see the EUS image now?
Yes, we can.
Yeah, from lower body of stoma, I will touch the posterior wall and aspirate the air and try to inflate some amount of, by injection of some amount of clear saline into the balloon and try to get very good contact across the window. While I am withdrawing my scope, we can appreciate the pancreatic tissue here, splenic vessel here, and the main pancreatic duct here. Here, if you measure the dimension of main pancreatic duct, this is body area, but this about 3 millimeter. So a little bit enlarges the main pancreatic duct. And I will try to trace from body to tail area while rotating my scope to clockwise. Like this, we can see several vascular structures behind the pancreas, and also we can see the pancreatic duct going through the pancreatic parenchyma here. And down here is left kidney, and the kidney, this is calyx cell system, cortex here, and the renal vessels are here. And we can see main pancreatic duct here. But in the main pancreatic duct, still, this area is tail area of the pancreas, and it's a little bit dilated. Main duct is a little bit dilated from the body to tail area, again 3 millimeter. But in the pancreas parenchyma, there is fairly looks normal pancreas parenchyma. And now this area is the tail of the pancreas. Now we can see the splenic hilum here. We observed to the tail of the pancreas. Now I am trying to go back to the body and also try to go to the neck area of the pancreas. And we can appreciate pancreatic duct dilation and also cystic lesion here. This is the cyst. It is about 2.8 millimeter ACM in size, and it is located closely to the main pancreatic duct. So I will try to look at whether there is any clear communication with MPD and this cystic lesion. But this is MPD. MPD goes downward, and the cyst is located a little bit far from the MPD, some distance.
Dongman, where is the worrisome features that
A worrisome feature.
that's
Okay.
described before?
Yeah. Worrisome feature, if you can find any mural nodule or papillary projection inside the cyst, then we can measure the dimension, and it can be the worrisome features. But in this case, the cyst wall is relatively smooth. It shows a little bit of lobulated margin. When I say lobulated, it means lobular appearance on this part and also this part. This lobulated, and there is septation here. Here, there is septation. So it is not unilocular cyst, it is oligolocular cyst. For oligolocular cyst, the differential diagnosis is quite difficult, and there are a lot of overlaps. It can be IPMN branch duct type, it can be mucinous cystic neoplasm, or it can be serous cystic neoplasm. So for the differential diagnosis, I think just morphologic evaluation is not specific enough. Considering the main duct dilation, I originally suspected there can be some communication with the cyst and the main pancreatic duct, but until now, I cannot see clearly the communication between cyst and MPD. So P-duct shows, this is aged female, so senile change also can cause a mild dilation of the pancreatic duct. Here. I will go to the second duodenal portion. This is a transgastric view. But before going to puncture, I will check the pancreas head from transduodenal view. I push my scope deep into the D2 area first. This is deep D2. And from here, while withdrawing my scope and also inflating the balloon, I generally recommend to my colleagues to use balloon, even for linear use. In some countries, they don't use balloon, but to get a good acoustic coupling, I think it is wise to use balloons. As in here, in the duodenum, when the patient is left lateral decurvatus position, D1 or D2 area usually have a lot of air, so it actually interferes the good EUS view. So in that case, we can do suction and the balloon, and we can try to observe the pancreas here. This is pancreas here. From here, I will try to pull my scope back little by little and try to look at the head area of the pancreas. This is, we can see the pancreatic duct here, and this is a splenic vessel. This is SMV, and SMV joins with the splenic vein, and this is main portal vein, and this crossing vessel is, this is artery, celiac artery, going to the hepatic artery, and it shows gastroduodenal branch. From here, we can see different view of the cyst in the head of the neck area of the pancreas here. This is the cyst. Again, we can see some septation here. Above is hepatic artery branch, and down here is cyst, and here is main pancreatic duct here. I will try to find whether there is any communication between the cyst and the MPD. This is transduodenal view. It is very close here, but I'm not sure.
So it seems that more easy to be puncture, to do the puncture through the stomach rather than the duodenum, isn't it?
Yes, the transgastric puncture gives a more favorable angle. This is the scope position is actually curved and angulated. So puncture from this angle is different, and another one is interfering vessel here. So, but for observation, it's better to use different stations to see the whole picture of the cyst. So until now, I cannot see clearly the communication between cyst and main pancreatic duct. So this is, I think, a typical example of indeterminate cyst, which means even after EUS examination, we cannot clearly, confidently say that this is mucinous or serous or IPMN. So for the differential diagnosis, now I'm going to puncture the cyst using 19 gauge FNA needle. And then firstly, I will try to do Moray forceps biopsy and then aspirate the cystic fluid. We can do aspiration first. After puncture, we can remove the stylet and aspirate, and then we can do Moray forceps biopsy. In that case, trapped air inside the needle can go into the cyst, and it can interfere the visual field. So to avoid that, I will try Moray forceps biopsy first. Now my needle is located at the tip of echo endoscope, and here we can see the needle tip here. If I move it, it moves like this. So locate the needle tip first, and then I'll try to pull back my echo endoscope and try to get a stable position because of respiration, and the patient sometimes aortic pulsation can create some movement of the cyst. There is no big intervening vessel, so I'm going to puncture probably at this angle. No, this is not punctured. The cyst wall is not punctured yet. There is indentation there. So try to get a good. You don't need to hurry. Big sufficient space is important. 자, 이 정도 하고, 그렇죠? 너무 잡지 말고. Still, I think the tip is outside, so this is better. Yeah.
You're in.
Now the cyst wall is punctured, and I will retract the needle tip a little bit and try to expose the Moray forceps. Can you see the tip, echogenic tip of Moray forceps? Please open the forceps. Open. Now the forceps is opened here. Can you see the Y-shaped forceps tip?
Yes,
Yes,
very
we can.
clearly.
Yeah.
So you
then-
preloaded the Moray forceps before you do the puncture.
I exposed, the forceps was exposed. So because of that, the puncture was not clean. So I retracted the forceps a little bit backward and then did puncture. Now I am trying to grab the cyst wall, gentle push and close. Now I closed my faucet, but there is some time lag. So after closing, it's better to wait a little bit, a little more second, and try to pull back. Now you can see, probably appreciate the tenting sign. The wall is, can you see the tenting sign?
Yes.
Yes.
The
we
cyst
can.
wall is drawn backward. And then I can confidently say that we grabbed some amount of cyst wall and pull it back. And then I will fix the right and left knob and the up down knob, and I will retrieve the sample. Okay. 룸 뷰를 보여주세요. 오픈. 네. Here I can see fairly large amount of tissue. I'm not sure the camera can get this image. Can you see this? The small is macroscopically it is clearly visible. Although the camera is not very good, I can see clearly whitish cyst wall tissue. So if you see this amount of tissue, I think it is enough. But usually I do at least 2 or 3 biopsies from the cyst wall. 주세요.
So usually, how many biopsy you will taken from a cyst wall?
2 or 3.
2 or 3.
2 or 3. Even though I can see fairly large amount of tissue just by one biopsy, for sometimes it cannot, just for safety, I do at least 2 or 3 biopsies. If I always try to look at the sample macroscopically. If I feel the quality is not very good, then I can go up to 4 or 5 biopsies.
So if during EUS you found a mural nodule, would you biopsy both the mural nodule and the wall, or just the nodule?
Nodule first, if it is possible. But if the nodule is located not in the opposite side, sometimes it is difficult to target. On those cases, we can target the cyst wall. Now the forceps is going in again, open. Now you can see the forceps is opened again. I will try to push the biopsy forceps against the wall and grab. 닫고. I wait a little bit of time. Now I can see tenting sign again. I will try to remove the sample again. Yeah. A little bit smaller than previous sample, but it is still a macroscopically visible tissue amount. Sorry. Sorry. Not clearly visible. Now I'm going to do, because we got a clearly visible amount of tissue. 한번 더 할까요? I will do one more. My nurse wants one more biopsy. It's better to follow.
So Dong Wan, one quick question. So
yes,
in terms of the sequence of the procedure, so do you always biopsy first before aspirating the cyst fluid, or what's your preference?
If the cyst is large, aspiration first, and relieve the tension, and then do biopsy. But sometimes when the cyst is septated, after aspiration, it is difficult to have some space. And then biopsy process can become very difficult. In those cases, biopsy first, and then we can do aspiration of the cyst. In those cases, sometimes cystic fluid, now you can see why I prefer to do biopsy first. Trapped air can go inside the cyst, and the visual field becomes very poor. So this is because now my forceps is going inside. Yeah, now open. Now the forceps is inside. But I will try to now say have some space here. Okay. And then 오픈됐죠? 오픈했죠? 네. 오픈했어요? 네, open. Okay, try to grab, cut, and pull the tissue back. 네. Okay.
So Dong Wan, is bleeding
Yes.
common after biopsy like this? And if it happens, what should we do?
This case is, I don't think this case showed bleeding. The trapped air went inside the cyst, and because of the echogenic cloud is visible. If the bleeding happens, it's usually minor bleeding, so don't need to worry much about it. Cystic fluid aspiration. Now we completed 3 biopsies from the cyst wall, and we are going to try the aspiration of cystic fluid from here. 잠깐 놔두세요.
But sometimes after the biopsy, the cyst fluid would be contaminated by blood. Would it
Yes.
affect your fluid analysis?
A little bit, but doesn't affect much. It is because in the blood, there is some amount of amylase, but it's not that high like 700, 800 unless the patient has pancreatitis. And the CA level, I don't think CA level will change much, even though there is some blood contamination.
Because my lab sometimes comment that my sample was bloody, and then the machine cannot extract the fluid for analysis. So I worry that blood actually may bother the analysis. And also, obviously,
I will remove the needle. Just a moment. No. I
And
think
obviously
some
this-
amount of tissue is caught at the needle tip. So aspiration is not going very well. So I will check the needle tip. My nurse is checking the needle tip and try to push out some amount of tissue at the tip of needle, and we will do aspiration again. Yes, please go on.
And also, this is not a aseptic technique. So would it increase the chance of infection of the cyst content after you puncture? Do you regularly use antibiotic?
Yes, in all the cases receive IV antibiotics when we are dealing with cyst aspiration or cyst biopsy. I think it would be wise to use antibiotics. And sometimes there can be some leakage of cystic fluid. So if the procedure time is long and difficult, there is some risk. But it is not severe. I don't think it is very severe risk because we are dealing with mostly benign lesions, not malignant lesion or.
What is the result of this biopsy that you have done in recent years? Is it increasing your diagnostic yield significantly?
Yes, of course. We can get confidence on our differential diagnosis. Without it, we actually, before Moray forceps biopsy, when we analyzed our data, I cannot remember the exact percentage, but significant percentage actually changed our therapeutic strategy because of this biopsy result.
So is it now your routine to use Moray forceps for all the pancreatic cystic lesions?
Yeah, with cyst more than 2.5 or 3 cm in size, and the differential diagnosis is necessary. Yes, we do. Moray-Posey biopsy is much better than just the cystic fluid analysis or genetic analysis, or I think there is some mucinous material, so we can get some amount of fluid, but there is stickiness, and slowly the fluid is coming. So it is definitely mucinous lesion, not serous one. When the aspirated amount of fluid is small, like just 1 cc, then we usually dilute it 10 times. Once is after mixing with 9 cc saline, we can get 10 cc fluid and send it to amylase and CA analysis. Then when we get the result, we can multiply the result by the factor of 10. Then we can get, as you see here, there is some sludge-like mucinous material. Actually, it blocks further aspiration of cystic fluid, but I think we already have some amount of fluid, so we will stop the procedure here, and we will dilute this fluid, and we will send this fluid for analysis. Okay.
So very nice demonstration, Dong Wan. So you also you give us some helpful hints on the use of this technique.
Yeah, but I wanted to aspirate all the cystic fluid. If it is, everything goes smooth, but this was a little bit sticky fluid and difficult to aspirate the whole fluid. But I think we achieved most of the goals for today's live. So if you have any further question or comment, I will be happy to answer or receive it.
So in the interest of time, we may not be able to take questions for now, but I think during the live demo, I think you clarified a lot of the, some of the technical questions. So we like your demonstration a lot. So thank you.
Thank you very much.
Thank you.
Thank you. Thank you very much. Yes.